Good afternoon. And today we have an honor to feature on our channel Dr. Nora Ghodousi-Zaghi. She's a brief pediatric dentist. Good afternoon, doctor.
Good afternoon. I'm excited to be here.
We're actually very honored to have such a wonderful guest. We're going to talk a lot about sleep and breathing for our future generation. And again, thank you very much to our audience. If you want to help us to promote our mission to make this world a better place, please click like and share button. This way your friends and family can get a lot of valuable information. And you help us to make this world a better place, because well-rested person, and actually little person or big person, definitely a happy person. So I would like to introduce Dr. Ghodousi-Zaghi to our audience. This is the first time we featured pediatric dentists who provide functional and integrative pediatric oral health care, as well as airway interceptive orthodontics. And she looked at the whole body and whole well-being of the child. She's also diplomat of American Academy of Pediatric Dentistry. She's a published author, researcher, and educator. The important feature, Dr. Nora, she has advanced knowledge in myofunctional therapy and actually do a lot of work with the breathing, which is very important foundation of health. She have expertise in the field of sleep, breathing, ankyloglossia, which is a tongue tie, early interceptive orthodontics, and knowledge in oral motor and feeding therapy. So the care starts very early for the human being. And we're going to talk a lot about raising the future generation happy and healthy, because role of pediatric dentistry not only prevent cavities, it's so much wider and broader as we learn. So, Dr. Nora, my first question to you, how your journey begin? What was that lighting bulb? What make you become so interested in that field, which I find absolutely fascinating, and your work absolutely amazing?
Thank you. Thank you so much. So yeah, I began my journey into functional and integrative care and dentistry, specifically airway-centered dentistry, when I was in my residency. I was getting referrals from the orthodontic department to do premolar extractions. And I had a residency mentor that would tell me, Dr. Nora, you need to provide informed consent before performing a procedure. And when you take a referral from another providing doctor, it's important for you to identify the risks and benefits of the procedure, as well as the alternatives before performing it. And I asked her, so what are the alternatives? What else can we do? And she said, well, what you can do is create some more space in the mouth for the tongue so that the child can have not have premolar extractions, because it can therefore affect their sleep and breathing in the future. So I learned this really simple concept: form follows function. So wow, not everything is genetically bound. How we eat, our structure, how we breathe, it all connects to how we grow. And I started to notice an inherent difference in how our patients' faces grew differently based on how oral habits were, what their environmental influences were, and what their structural issues were, but also how they breathe.
That's absolutely great, because 4 bicuspid extraction used to make me very uncomfortable and still make me very uncomfortable. I was always against it, and I never extracted premolars. It made me feel ooh. So it's wonderful what we had the same thoughts. Now I would like to ask you, what's different in your evaluation of pediatric patient from regular pediatric dentist?
Yeah. So that's a very good question. So when I see a patient, I spend about 45 minutes to an hour doing a comprehensive evaluation on them. And this is because it's not just about the teeth. We're not just looking for decay, it's about prevention. So my intake discusses nutrition, it discusses sleep, it discusses breathing, it discusses birth history, it discusses the environment. I want to know if there's clenching, if there's grinding, what's going on in the child's behavior, for the child's behavior. There's so much that we need to understand about the patient before we do treatment plans for them. So that's what functional dentistry is. It's understanding the root cause of disease and treating the root cause rather than just putting a Band-Aid on the disease.
Yeah, that's so wonderful, and because basically you set up the foundation of somebody's health.
Absolutely.
And I think your long intake form, you actually introduce parent to the child, because parent can look at the child through the different lenses. You kind of point it. Okay, you never pay attention how your child sleep. Yes, they sleep in the bed. That's it. Now, the parent gonna look totally different. You point the light on how child eat.
Yeah, absolutely. So a lot of parents, so what I do in my intake is I actually include the Ferris 6 study inside of my intake. And that's because the Ferris 6, for those of you that don't know, it's a list of, it's a 6 most statistically significant behaviors that are associated with sleep disordered breathing. And the more yeses that you might have on the Ferris 6, the more likely you are for your child to have sleep disordered breathing. And this includes mouth breathing, tonsillar hypertrophy, intermolar width. It includes a plethora of information from the original, and this is created by the Breathe Institute as well as Cynthia Peterson. And when the parents fill out that Ferris 6 study, they actually sometimes come back to me on the day of the appointment and they tell me, oh, Dr. Nara, I wrote no on mouth breathing, but then I started to notice that my child's mouth is open at night when they're sleeping. And then they start to become more aware, and they Google and they look up things, and they notice, hey, my child might have a sleep issue that is related to their symptoms that they're presenting with today. So the parent is being led to where the child is today.
I know what you do a lot of work around tongue tie. Dr. Zaghi, your husband, he's actually the world-known expert in ankyloglossia. Can you educate us a little bit more in general why position or anatomical features of the tongue, such as a tongue tie, is so important, and how it affects function in the future and sleeping and all of that? Why is it so important?
Yeah, absolutely. So first we have to understand what a tongue tie is. So when the tongue, everybody has a frenulum, and there's a frenulum right underneath the tongue, and that frenulum connects the tongue to the floor of the mouth. And when that frenulum is excessively short or it's tied down, what happens is that it can lead to sleep issues, breathing issues, behavior issues functioning like breastfeeding, and it can also lead to issues such as speech and language issues and fluency issues as well. It's important to note that the tongue is the driving force of the premaxilla, which is our upper jaws. And when the tongue is tied down, we're more likely to have low tone, and we're more likely to have low tongue position, meaning that the tongue will remain on the floor of the mouth. We need that tongue to stay up on the roof of the mouth in order to have the appropriate function of the previous things that I've mentioned, as well as for the formation of our teeth and to grow and develop in our jaws, and also for our faces. If our tongue is low, what happens is that when we're asleep, all the muscles of our body relax, including the 16 muscles of our tongue. So if our tongue is tied down and sitting low, what would happen is that the tongue will fall back into the airway and cause obstructions, which leads to sleep disordered breathing. And we also notice that we'll notice that patients will have high and narrow palates. So there might not be, because they've developed that way from those tongue ties being undiagnosed, and the roof of the mouth will remain small, which therefore will cause underdevelopment in the nasal cavity, because the floor of the nose is the roof of the mouth. So it's a cycle of oral dysfunction. Tongue tie is one piece of the puzzle, but there are many pieces of the puzzle that need to be addressed when addressing tongue tie.
I really like what you look at our work in our field like a detective. What we really have to find the root cause of a disease, not just put a bandage on a wound and make people live with that bandage, which later on become a CPAP machine or oral appliance. Yes, unfortunately, but trying to set the foundation right. And as far as I understand, the foundation would be the nose breathing. I would like to ask you the practical question. What some practical tools from early on, from birth, to optimize the nasal breathing? Because I think that's actually the foundation of our health.
Absolutely, yes. In order for us to nasal breathe and not to mouth breathe, we need to be able to keep the nose clear. And you can do this at birth. At birth, you can use something called saline drops and place saline drops in the nose, and then use something called a nasal aspirator to help remove any congestion that might be in the nose. When patients get a little bit older, you can use something called a pediatric Neil MD sinus rinse. You use pre-filtered water, place a packet in there, and then you can use the solution, mix it up, and rinse not only the nasal cavity, but the sinuses as well. And this is the adult version. At about 4 months old and up, if you don't feel comfortable using the Neil MD sinus rinses, you can use something called X-Lear drops. And what X-Lear drops or spray do is they allow the xylitol, which is present in the formula, to break down the congestion that's in the nasal cavity. Xylitol is a very safe type of sugar that's actually made from birch tree, and what it does is it helps break down congestion. But when we use it in our oral cavity, it helps decrease the harmful bacteria to binding to tooth structure that can cause decay. So these are all really helpful tools. But also, if you have a child that's with having their tongue down or mouth breathing, what you can do if the nose is clear and the patient's not sick, just gently place your fingers on the soft part of the chin to help elevate the muscles of the tongue up on the roof of the mouth, and gently close lips together so the patient can be reminded to breathe from the nose. Another thing that you can do is when the child is over the age of 5 and they've already been evaluated by a functional dentist, a myofunctional therapist, or an ENT, you can begin using something called mouth tape. And mouth tape can be myotape, Somnifix. There's so many different types. It doesn't have to be one strip of duct tape that goes directly over the lips. There are many safe options that have air holes that are directly in the center of the mouth, because what it does is it acts as a safety tool in case you do need to breathe from the mouth, but also acts as a gentle reminder to keep the lips together.
I think it's such a great advice, and it's like a whole, by the age. And I think if you set up foundation right from the start, like I have a lot of patients and I recommend the nail mat and said, I cannot stand it. I use it, but if you start early, when you're adult and you get respiratory tract infection, that's not a problem to clean the nose. Mm-hmm. And in a lot of cultures, like in the Indian Ayurveda, that's actually foundation as well, to have a nose clean and breathe through the nose for better mental capacity. But my question towards the same thing, for our parents who listen to our interview, what would be the red flag of sleep disorder breathing? Mm-hmm. How to recognize what, breathing is not exactly right and you need to act.
Yes, so absolutely. So one of the biggest red flags of sleep disordered breathing is open mouth posture and mouth breathing. Mouth breathing is one of the first red flags, and it leads to something called noisy breathing, which therefore can lead to obstructions and sleep apnea. What we want to do is catch the smoke before the fire. And if we see this open mouth posture, the mouth breathing, what we need to do is identify the why. and start to treat early. There are many things that we can do to treat early. You can do these simple things at home, like we talked about earlier, like keeping the nose clear. And then we have to, if that continues to fester, you've done all of those things, and the patient is still mouth breathing, then we need to identify further as to what can be the root cause. Is there some sort of nasal obstruction that's causing this? Is there is there underdeveloped jaws that we need to address? Is there a tie? These are all things that can lead to sleep disordered breathing. In
No,
addition, in addition, I would like to mention that sometimes mouth breathing might not be so obvious, but some signs of sleep disordered breathing can include behavior issues. And a lot of times, like for example, a lot of patients might have sleep disordered breathing that masks as ADHD-like symptoms. And that's because when we're mouth breathing, we have an increase of sympathetic tone, meaning that the patient's constantly in fight or flight because they didn't get that rested sleep to get back into homeostasis. And also when we get that deep, juicy sleep, our memory starts to consolidate. We have growth hormone being released. So not only are our children doing not well in school, they might not be growing physically as well. They might be falling asleep at the desk, or they might be overtired and not being able to sit still and get it and pay attention because they haven't gotten that deep rested sleep. So it's really important just to note that tongue tie is just one aspect of the problem. And when we're looking at a tie, we have to look at all of these dysfunctions that could be a result of this issue.
I have to apologize to I had a little technical difficulties. I blocked the noise. So I have a next question. Thank you very much. It's such a great answer about sleep disorder breathing. I would like to ask you, you are a big proponent of myofunctional therapy. And I'm going to ask several questions about that. It's still not recognized by medical community and not recognized among the general population. I would like to know, Brief Institute, and personally your opinion about community education strategy, how we can break that barrier to educate people about the root cause and proper treatment. What Brief Institute do to increase the awareness?
Yeah, absolutely. So the Breathe Institute is committed to doing 1/3 of patient education, 1/3 patient care, and 1/3 of research. And all of these things are important. If we didn't have one, the Breathe Institute wouldn't be where it is and wouldn't have the impact on patients that it does have today. So when we're looking at myofunctional therapy specifically, which is what your question was about, how myofunctional therapy isn't so recognized, well, what we have to understand is that we need the muscles of the tongue, lips, and jaws to be strengthened in order to prevent the dysfunction from reoccurring. Meaning that when we're seeing this low tongue posture and low tone, we need to address the strength of the muscles of the tongues, lips, cheeks, and jaws in order to improve these things so that we can improve the dysfunction. This can include seeing patients with thrusts, tongue thrusts, lifts. We also see patients having low tongue posture and developing these high and narrow palates. So if we can get the tongue up, that will improve our structure, which will therefore improve our breathing.
We're talking about, myofunctional therapy and about nose breathing and about ankyloglossia. Those are very important factors. But I know you mentioned to me tongue need to have a space. So you start early on with the bicuspid extraction, rebellion. You didn't want to do that. How to create the space and why is that important to have a space for the tongue. And for a lot of people who didn't start right early and they have a very high palate and not enough space, what can be done? And I want you to educate us about strategy for treatment and modern strategy for treatment of that, dysfunction, I guess.
Yeah, absolutely. So it's important to have space in the mouth to produce specific speech sounds, for example, and not having space and having these restrictions can impact speech even more than ties. And that's something that's missed and something that's overlooked far too often. If we're just looking at the tie, we're missing the bigger picture. And what we're noticing is that when patients have these high and narrow palates and they're not being addressed, it can impact, and the tie is released, it can impact the way that they continue to breathe and function, and they'll thrust, their shoulders will remain forward so that they can breathe, the tongue will remain out of the mouth, and that can cause a lot of issues in the future, like neck and shoulder pain, tension, postural issues, and so forth. So how to improve space, that can be improved very, very early on in life. I believe that you can start improving the space in the room of the mouth at birth by doing age appropriate teethers, using appropriate appliances at the appropriate ages. There's wonderful appliance companies out there that you can start working with as a practitioner, and also working with your therapists. There's oral, motor, and feeding therapists that can improve the strength and strengthen the muscles of the tongue, lips, and jaws at young ages. And then when child gets a little bit older, you can do traditional myofunctional therapies, such as around age of 5 years old and up. And I personally start working with appliances at the ages of 6 months and up with children. I start noticing, what does the child's tongue look like? Where is it positioned? Even when they don't have teeth, we can start to notice that there's an underdevelopment of the jaws. And then when the teeth do come in and we're noticing that there's no spacing between them, they might look beautiful and nice and straight, but we're noticing that there's no spaces. And this is a big red flag, not having spaces between the teeth. So we need to create those spaces, not just because the permanent teeth need to take the space, but because we need to improve the space for the tongue to remain up on the roof of the mouth, and if it doesn't, it will impact speech, it will impact breathing, it will impact sleep, which will therefore impact their behavior and potentially impact their growth and function in the future.
Yeah. Oh, thank you very much. It's such a wonderful answer. And I would like to ask about the appliances, what you recommend to use early. Would be something like a Myo brace or Myo munchie, not a pacifier?
Yeah, so that's a great question. A lot of patients come to me and they ask, because in my practice, I specifically do a lot of growth and development and creating space in the mouth, because I find it to be very impactful on the child's life, as well as very impactful in their journeys and their journeys of wellness. So the patients come to me and they ask me, what's the best appliance? And what we need to evaluate is, first and foremost, as a practitioner, you have to have all the tools in your toolbox so that you can be able to treat a myriad of these issues, because patients present differently, and no two patients will have the same treatment plan, even if they have the same exact symptoms, similar structure. I don't think I would have I've never had the same treatment plan for any two patients, because every child is different. Their behavior is different. Their lifestyle is different. What they can do or what they can tolerate, their cooperation level is completely different. And, sometimes for sleep, the pacifier is a very necessary tool for family. And I just like how you mentioned, I try not to have a judgmental space, because I understand as a mom myself, it's hard to get that sleep. Therefore, I really encourage parents to work with us on replacement strategies and redirection of the behavior, because sometimes when we're noticing the need for pacifiers or habits, it might be masking a greater airway issue. And that airway issue can mean that there's underdevelopment of the jaw, or the tongue is not able to stay on the roof of the mouth so the child can self-soothe. And we might need to redirect around the age of 6 to 10 months. And I generally start redirecting at that age with things like the baby munchie, or using pacifier weaning tools to help with gaining the function and the growth and structure of the craniofacial structure that we need.
Yeah, that's a great answer, and it will set the direction. I would like to ask you specifically about expansion, because expansion, traditionally done with expanders, and now clear aligners come to the scene to use phase one orthodontics to set up the strategy this way. Please give us your opinion on clear aligners for the expansion for younger kids.
Great question. So I come from there's something called skeletal expansion, and then something called dentoalveolar expansion. And it's thought that when we do rapid palatal expansion which is a traditional type of expansion, we see changes at the basal structure level of the maxilla, meaning that we gain intermaxillary width, which is what we would want to see. Whereas when we do dentoalveolar expansion, then we just gain changes from where the teeth sit in the bone, not necessarily intermaxillary changes at the basal level. So, what I believe is that when children are young, we have the ability for the tongue to actually change the skeletal structure of our maxilla, meaning that the tongue itself remaining on the roof of the mouth can help shift and change our intermaxillary width. And this has been proven. If you look, there's studies that show there's one study specifically that shows that it's with the palatal version, flexi version, Essex retainer, where they place electrodes and they place the tongue up, and they found that it provides almost 700 grams of force in some patients, and an average of around 500 grams. It only takes about 1.5 grams of force to move a tooth, and it takes about like 5 ounces of force to actually provide that skeletal expansion that we're doing. So it's really impactful to get the tongue up, and using these clear aligners can help create space for the tongue to stay up on the roof of the mouth, which really is going to change the structure. I personally take a look at the patient, and I determine if clear aligners in itself are going to do the job, or if I determine if additional expansion prior would be necessary. But I think it's really great to have multiple tools in the toolbox to be able to approach these patients.
This is such a wonderful, and I would say futuristic answer. I hope, parents lean towards clear aligners rather than expansion, but of course it's whatever provider can explain. So I love what Brief Institute do so much into research, because, actually to be the recognized expert in this, interesting world, you have to support your treatment strategy with the research, and Brief Institute helps so much. So my last question to you, doctor, would be, what are some new updates in the world of research in relationship of pediatric dentistry and mouth breathing?
Yeah, so I think that's really, the research is constantly getting out there and shifting and changing our world, which also shapes and changes how our patients are being treated. So Dr. Zaghi is about to publish a research article, which I think is really exciting, showing about 91% of improvement in professional singers in their voice quality and range after releases. So even professional singers who've made a career out of their voice have found improvements in their breathing and their voice while using myofunctional therapy alongside release. So I find that very fascinating, as well as the research study that's been published by Dr. Yoon and Rebecca Bacow and their team of professionals, where they found that rapid palatal expansion has had an impact on shrinking tonsils and adenoids when it's occupied less than 50% of the airway. And what we are noticing is that since, like I mentioned before, the roof of the mouth is the floor of the nose, when we're expanding the roof of the mouth, we're also expanding the nasal cavity. So patients are able to breathe better from their nose. The tongue is remaining up. And what happens is that they're switching from mouth breathing to nasal breathing. when they're nasal breathing, their inflammation isn't constantly provoking the tonsils and adenoids and causing hypertrophy. So when we're looking at this holistically, what we're seeing is that it's not just about the tongue, but it's really about the space in the mouth, and it's about function, like myofunctional therapy, speech therapy. It's about breathing. It's about sleep. There's so much when we're addressing these patients.
Oh, thank you very much, doctor. It's been so wonderful to learn from you and, to learn about so many new research and new technique. So we're looking forward to have our conversation again, to continue our conversation. Thank you.
It was a pleasure being here. Thank you so much.